So doctors, I would like to show you today's topic, orofacial clefts. Of course, speech difficulties. What about speech problems? Children with an unpaired cleft palate have a nasal quality of their speech, called hypernasality. Because of because air escapes through gap in the roof of mouth and out of nose. This inability to use palate muscles to block off nasal cavity from the mouth so that air flows through mouth is called velopharyngeal incompetence. These children may also have difficulty generating enough air pressure to produce sentence sounds. After cleft palate repair, most children develop near normal speech, and hearing loss further hampers proper development of speech. Retardation of consonants, hypernasality, articulation defects, and hearing problems. It is there are standard problems in patients with lip and palate clefts. But you understand that this person doesn't have any problems with speech. Hearing loss. Next big group of problems. Any child with a cleft palate is at risk of developing frequent ear infections. I would like to mention you that the eustachian tube, which drains the middle ear, malfunctions, causing persistent fluid buildup in the middle ear. As shown here, eustachian tube in child is shorter and wider than in adult, and it can cause frequent ear infections. Otitis, like otitis media. A combination of fluid and repeat ear infections can cause scarring of the tympanic membrane, eardrum, and hearing loss. Pressure equalizing eardrum tubes can be inserted at the time of lip or palate repair to drain the middle ear and reduce the risk of ear infection and hearing loss. And next big group of problems, the associated anomalies. Congenital heart defects, mental retardation. What about diagnosis? Cleft lip only is easily recognized on physical examination of the newborn. Cleft palate is determined by direct visualization of the pharynx after delivery. Palpation of the palate with a finger may be useful, but prenatal diagnosis should not be included in surveillance data unless it is confirmed postnatally. As can you see, the shown ultrasound image of cleft lip only, or here, or here. Orofacial clefts can be detected during pregnancy by a routine ultrasound. Cleft lip can be easily diagnosed by performing ultrasonography in the second trimester. Usually, orofacial clefts are diagnosed when the baby is born. As for me, this baby is not satisfied. He was born. Minor clefts might not be diagnosed until later in life. Diagnosis can also be made by physical examination. Let's talk about advantages of prenatal diagnosis. Time for parental education. Parents will have enough time to get education. Time for parental psychological preparation. It is very important too. Opportunity to investigate other associated anomalies. Very often, lip and palate clefts are associated with other anomalies. It gives parents the choice of continuing their pregnancy and opportunity for fetal surgery. Why not? And let's talk about variability of different clefts. Variability of phenotype. The easiest type is bifid uvula. More hard cleft hard palate. Then cleft hard palate till foramen incisivum. Sorry, it is cleft soft palate, cleft hard palate, cleft hard palate till incisal foramen. Cleft hard palate with cleft lip, specified as unilateral, and cleft hard palate with bilateral cleft lip. Now let's talk about associated syndromes. Clefts have been identified as a feature in over 300 syndromes, most of which are rare. The most syndromes are Stickler syndrome, ophthalmic and musculoskeletal abnormalities, Down's syndrome, Apert syndrome, Pierre-Robin syndrome, van der Wood syndrome. Associated syndromes. Stickler syndrome. Stickler syndrome is a group of hereditary conditions characterized by a distinctive facial appearance, eye abnormalities, hearing loss, and joint problems. A characteristic feature of Stickler syndrome is a somewhat flattened facial appearance, like here. This appearance results from underdeveloped bones in the middle of the face, including the cheekbones and the bridge of the nose. A particular group of physical features called Pierre-Robin sequence is also common in people with Stickler syndrome. About Pierre-Robin sequence, I will tell you later. What does it mean? Stickler syndrome. It is syndrome called ophthalmic and associated ophthalmic and musculoskeletal abnormalities like myopia, scoliosis, mitral valve prolapse, hearing loss, and Pierre-Robin sequence. Down syndrome. Down syndrome, also known as trisomy 21, is a genetic disorder caused by the presence of all or part of a third copy of chromosome 21. It is usually associated with physical growth delays, mild to moderate intellectual disability, and characteristic facial features. The average IQ of a young adult with Down syndrome is 50, equivalent to the mental ability of an 8 or 9-year-old child, but this can vary widely. Apert syndrome. It is a rare condition where your baby is born with physical abnormalities because joints in their skull close too early. And this syndrome, characterized by skull, head is taller than normal and appears pointed at the top. It's called acrocephaly. The backside is flat, high or broad forehead. Eyes are widely spaced on the face and may show signs of bulging or slanting downward. Face. Flat or big nose, an opening in the roof of the mouth, cleft palate, or face is not symmetrical. Hands and feet. Short fingers with wide thumbs. And fingers or toes connect. It's called syndactyly. Associated syndromes. Pierre-Robin syndrome. It is a rare congenital birth defect characterized by an underdeveloped jaw, backward displacement of the tongue, and upper airway obstruction. Cleft palate is also commonly present in children with Pierre-Robin sequence. So, main characteristics of this pathology: micrognathia, glossoptosis, cleft palate. The overall impression is of bird face. And Vanderwood syndrome. It is a rare genetic disorder characterized by various structural deformities of the mouth. The disorder affects between 1 and 3 children in every 100 sounds and is caused by a variety of mutations in the IRF6 gene of chromosome 1. This gene is involved in the formation of the roof of the mouth and other structures during development. It is characterized by a combination of a cleft lip and or cleft palate with a pit or a slit on both sides of the lower lip. Saliva will often come out of these slits because they connect to the drainage of salivary glands beneath the skin. And in oral cavity, these patients can have missing teeth called hypodontia. And different syndromes include a Robin sequence. What does it mean? A Robin sequence is characterized by small jaw in size, micrognathia, or setback from the upper jaw, retrognathia. As a result, the tongue tends to be displaced back towards the throat, where it can fall back and obstruct the airway. Glossoptosis. Most infants, but not all, will also have a cleft palate, but none will have a cleft lip. Some cases may present a U-shaped cleft of the palate. And so rare situation called amniotic band sequence. Birth defects caused by entrapment of fetal parts in fibrous amniotic bands while in utero. This should not be counted as cleft lip and palate. And doctors, I would like to emphasize you that treatment of lip and palate clefts is multidisciplinary. In this treatment take participation genetics scientists, pediatrician, pedodontists, orthodontists, oral and maxillofacial surgeon, prosthodontic surgeon, and ENT surgeon, plastic surgeon, psychiatrist, psychometrist, speech therapist, social worker. Please notice that 1/3 of that team, they are dentists. And all that specialists must be connected into cleft team. Please, nota bene, once the child is born with cleft lip and palate, the services of a team of specialists are needed to care for it until adolescence. So, and in this table, there are shown stages, timing and sequencing of surgical orthodontic treatment, patients with lip and palate clefts. At the age of 0 to 3 days, must be performed counseling and feeding plate fitting to normalize feeding. From 4 to 6 months, surgical close of lip. 18 months to 2 years, surgical closure of palate. 1 to 3 years, indirect speech therapy by parents under guidance of speech therapists. At the age of 3-6 years, speech therapy plus NAS endoscopy and maybe pharyngoplasty. NAS endoscopy to diagnose some violation of normal function of uvula. 9 to 11 years, alveolar bore grafting and plus minus pre-grafting orthodontic therapy. 14 years, comprehensive orthodontic therapy. And, if it need, 18 years, orthodontic surgery and lip or nose revision surgery, plastic surgery. We need to remember that parents counseling about immediate and long-term implications of cleft defect and necessary surgery. The imaginate problems of infant with cleft lip and palate are connected with feeding and prevention of aspiration and infection. Nasogastric tube feeding. Use of medicine dropper for feeding. For parenteral feeding. Breastfeeding is desirable but may not be successful, and expressing of milk may be most appropriate approach. Bottle feeding is usually achieved but with some difficulty due to their inability to generate sufficient suction. The nipple of feeding bottles should be positioned on non-cleft side and moved about or squeezed by parent. Cutting of a cross in nipple increases the volume of milk that flows, but only when the nipple is compressed, hence the child doesn't need to create suction. Here are some tips and tools to help when feeding a baby with a cleft. Nipples. There are special nipples that can help a baby get the most out of feeding. Nipple shape. There are two main shapes: straight standard nipples and wide, flat NUK or orthodontic nipples. Nipple length. The nipple should be long enough for baby's tongue to press against it. Nipple pliability. A soft nipple makes milk come out faster. Then the baby will not have to suck as much. Nipple hole size. The size of nipple hole can make milk come out faster or slower. X shape. And there are some commercially available bottles specifically designed for use with infants with cleft lip and palate. They include special needs feeding, Haberman, cleft palate nurser, Matt Johnson, and pig-on bottle. The caregiver provides a gentle squeeze of the bottle as the baby sucks to get milk. They are shown. And Family Class Feeder by Matt Johnson. Special Needs Feeder or Haberman Feeder. Pig-on Feeder. And Dr. Brown's Natural Flows. What features of feeding babies with cleft lip palate? Position the baby upright or slightly reclined. Position the nipple. It is important to put nipple under a hard bone in baby's mouth to help them squeeze milk out. Pacing during feeding. Carefully control flow of milk by squeezing bottle when baby is sucking and stopping if baby seems upset or overwhelmed. Oral facilitation. Use hand and fingers to help keep baby's mouth around nipple during feeding. Like here. Prevent swallowing of air. Burp the baby frequently as babies with a cleft swallow more air than other babies. Managing liquid in the nose. If milk comes through nose, position the baby up in an upright position. When squeeze less frequently to make the milk go down towards the belly. Consistency of feeder method. The baby should be fed in the same position with the same nipple and bottle for each feeding. This allows the baby to learn what to expect with feeding. Oral care. Clean the area around cleft using a washcloth after each feeding. Wet cloth with hydrogen peroxide or water, as advised by your doctor. Cup feeding. Most doctors recommend changing from a bottle to a cup before the palate is repaired. It can cause the scar not to heal if the baby sucks on a bottle after the surgery. Thicker liquids can be used to make it easier to drink when the baby is first trying a cup. Begin offering a cup for small amounts of liquid beginning at 6 months to help the baby with this transition. Solid foods. Solid foods can be given to the baby with cleft palate at about the same time as with any other baby. Breast milk. If attempts at breastfeeding are not successful, the mother can use a breast pump to get milk. Then the baby can drink the breast milk from a bottle. A very important stage or step for treatment that patients is pre-surgical taping. What does it mean? Facial taping with elastic devices is used for application of selective external pressure and may allow for improvement of lip and nasal position prior to the lip repair procedure. Some surgeons prefer pre-surgical orthopedic PSO appliances rather than lip taping to achieve the same goals. Pre-surgical orthopedics. Feeding plate obturates the cleft and restores the separation between oral and nasal cavities. It creates a rigid platform towards which the baby can press the nipple and extract the milk. It restores basic function of mastication, deglutition and speech production until the cleft, lip and or palate can be surgically corrected. Appliances are composed of a custom-made acrylic base plate that provides improved anchorage in the molding of lip, nasal and alveolar structures during the pre-surgical phase of treatment. Objective of this pre-surgical orthopedics: reduce severity of initial cleft deformity. Columella, non-surgical lengthening in bilateral clefts and uprighting in unilateral clefts. Reduction in the width of the alveolar cleft segments until passive contact of the gingival tissues is achieved. But we need to remember about complications and disadvantages of this device. First one, it is irritation of the oral mucosal or gingival tissue. Can be ulceration of intraoral tissues. The intranasal lining of the nasal tip can become inflamed. Skin irritation due to tape usage. Parent complications required. Molding plate might get dislodged and obstruct the airway. There are shown all stages to manufacture this device. First of all, in this patient, we need to take impression, manufacture individual impression tray, and with this individual impression tray, to get precise impression. with silicone or polyvinyl siloxane impression material. Then get plaster model and dental laboratory will manufacture this device. Please notice that the device must have a special parts to bend this device extraorally for prevention inspiration of this device. What goals of cleft lip repair? Of course, it is improve facial aesthetics by restoring nasal and lip contour. And this procedure can have place in age of 3 to 6 months. Since clefts of palate vary considerably in size, shape and degree of deformity, timing for operation should be individualized. Criteria: width of the cleft, adequacy of palatal parts, morphology of surrounding areas such as the width of the oropharynx, and neuromuscular function of soft palate and pharyngeal walls should affect decision. And we need to remember about a rule of 10. The surgeon usually uses a rule of 10. What does it mean? It means that for successful cleft lip repair, age must be approximately 10 weeks. The child weighs 10 pounds. The child has a hemoglobin of at least 10 grams. The child has a white count of no higher than 10,000. The child is at least 10 weeks of age. But there are some warnings for cleft lip repair in neonatal period. Investigation of any infection prior to operation. Bleeding and clotting times should be determined earlier. In child, if child is in good nutritional state and in fluid and electrolyte balance, feeding may be permitted to within 6 hours of the operation. Gentle aspiration of the nasopharynx minimizes the hazards of the common complications of atelectasis and or pneumonitis. The primary consideration is maintenance of a clean suture line and elimination of strain of the sutures. For these reasons, infant is fed with a medicine dropper and the arms are restrained with elbow cuffs. A fluid or semi-fluid diet is maintained for 3 weeks. The parent's hands, as well as toys and other foreign bodies, must be kept away from that palate. But what about cleft lip repair in childhood? Monitoring of hearing and middle ear function to ensure appropriate language and speech development. Causes of speech problems: developmental delay, hearing problems, oronasal fistula, dental malocclusion, velopharyngeal incompetence, VPI, detected by NAS endoscopy, corrected by pharyngeal flap surgery with reduces nasal airflow during speech. Should be performed before age of 6 years. Then, speech therapy. Regular dental care to minimize morbidity due to loss of teeth. It includes oral hygiene instruction and prophylactic measures to prevent dental caries and periodontal disease. Repair caries and malformed teeth. Orthodontics. Align the teeth in the arc before bone grafting of residual alveolar cleft prior to the eruption of the permanent canine or lateral incisor teeth. Alveolar bone grafting should be timed to precede the eruption of the canine tooth on the cleft side, which usually occurs at approximately 11 years of age. This provides a bony bridge across the cleft so that the canine tooth can erupt into this new bone and allows the tooth to have a healthy supporting periodontium. Let's talk about history of cleft lift repairing. In France, Ambroise Paré, in beginning of 15th century, one of the great surgical figures of Renaissance, used silver needles with tips of steel and thread of waxed linen, like here. In 1575, Paré popularized the term bec de lieur, or lip of hair, to describe a cleft lip. He was likely the first surgeon to include an illustration of the repaired lip in his surgical works. Johann Philipp Hoffmann of Heidelberg in 1686 described this snug cloth cap that extended over the cheeks and upper lip with hooks and threads to pull the edges of a cleft lip closer together. And I would like to tell you about principles of surgical markings in case of cleft lip repair.
In this animation is a variation of the Millard rotation advancement repair to close a left complete cleft lip. The Millard repair is the most common technique for cleft lip closure. Prior to making the first incision, the lip is first marked to properly plan incision placement. Points 1 are the edge of the lip commissure on both sides. Points 2 and 4 mark the lateral edges of the cupid's bow. Point 3 is the midpoint of the cupid's bow. Points 7 are the lateral aspect of the lateral nasal ala. Point 5 is placed such that the distance between points 7 and 5 is equidistant to the length between 7 and 2. The distance between 1 and 2 and 1 and 5 should be approximately equivalent. Point 8 is made 3/5 of the distance across the columella. Point 6 is the most superior and medial aspect of the lip skin available. Point 9 is variable depending on how much additional length is needed to drop the lip down for aligned closure. Keep in mind that the distance connecting 4, 8, and 9 is slightly longer than 5 and 6, as the rotation flap never unfurls perfectly straight. In this animation, you will see that the M and L lip flaps being discarded, though in actuality, these will be used to help with mucosal lining during closure. The red lines drawn here denote the planned incisions based on these markings. The back cut along the columella is variable depending on how much additional length is needed to drop the lip down for aligned and symmetric closure. Once the skin incisions have been made and the skin flaps undermined, the orbicularis muscle is detached on both sides from the nasal sill region. Once freed, the muscle layers are carefully and precisely closed with special emphasis along the white roll. The lateral cleft side flap is an advancement flap, while the medial non-cleft side is effectively a rotational flap.
As for me, it is so useful animation.
In this animation is a very
Now let's talk about cleft palate repair. This procedure has two main goals during infancy. First one, the watertight closure of the entire oronasal communication involving the hard and soft palate. The repair of the musculature within the soft palate that is critical for normal creation of speech. The exact timing of repair of a palate cleft is controversial. Generally, the volume must be closed prior to the development of speech sounds that require an intact palate. Average of this level of speech production is observed by about 18 months of age in the normally developing child. If the repair is completed after this time, compensatory speech articulations may result. Repair completed prior to this time allows for the intact volume to close effectively, appropriately, separating the nasopharynx from the oropharynx during certain speech sounds. When repair of the palate is performed between 9 and 18 months of age, the incidence of associated growth restriction affecting the maxillary development is approximately 25%. Cleft palate reconstruction requires the mobilization of multi-layered flaps to reconstruct the defect due to the failure of fusion of the palatal shelves. Surgeon must also reconstruct the musculature of the velopharyngeal mechanism. The musculature of the levator palatine is abnormally inserted on the posterior aspect of the hard palate and therefore must be disinserted and reconstructed in the midline. And now I would like to show you animation about the most common type of cleft palate repair, Forlov palatoplasty. But sometimes we can observe parapharyngeal flap. In very wide clefts, we used parapharyngeal flap as the primary palatoplasty procedure to assist in closure. The disadvantages of the pharyngeal flap are bleeding, snoring, obstructive sleep apnea, and hyponasality. What about secondary cleft palate surgery for management of velopharyngeal dysfunction? We talk about velopharyngeal insufficiency or VPI. What does it mean? Definition. It is inadequate closure of the nasopharyngeal airway port during speech production. Etiology of VPI: inadequate surgical repair of the musculature, congenital defects. How can we make diagnosis of VPI or velopharyngeal insufficiency? With the use of video fluoroscopy and nasopharyngoscopy. Video fluoroscopy are used to radiographically examine the upper airway with the aid of an oral contrast material. Nasopharyngoscopy allows for direct visualization of the upper airway and especially the velopharyngeal mechanism from the nasopharynx. Timing for velopharyngeal insufficiency surgery. We need to remember that VPI causes a hypernasal speech, and this surgical intervention must be ranging from 2.5 to 5 years of age. And we can use different operative techniques like the superiorly based pharyngeal flap, the sphincter pharyngoplasty, and the dynamic sphincter pharyngoplasty. Please now look at animation about 4 ways to treat velopharyngeal insufficiency.
Velopharyngeal insufficiency, or VPI, is a medical condition characterized by hypernasal speech and, if severe enough, food and liquid nasal regurgitation during swallow. During normal speech and swallow, the soft palate closes tight against the back wall of the pharynx, thereby completely separating the nasal cavity from the mouth. In patients suffering from VPI, there is a persistent opening between the soft palate and back wall during speech, denoted by the white arrows in this animation. This opening allows air escape during speech and food and liquid nasal regurgitation during swallow if severe enough. Surgical correction entails restoring velopharyngeal closure during speech and swallow, but without causing nasal obstruction. If the VPI defect is tiny, a needle can precisely bulk up the back wall of the pharynx with filler agents to allow for tight velopharynx closure. If the VPI defect is a bit larger but still small, or a submucous cleft is present, a double opposing Z-plasty, also known as furlow-palatoplasty, can be performed to both lengthen the soft palate as well as restore the proper reorientation of the muscular palatal sling. If the VPI defect is large with minimal lateral wall motion, a sphincter pharyngoplasty can be performed. This procedure recruits muscle and mucosa from the sides of the pharynx and rotates them horizontally across where the VPI defect is present. If the VPI defect is large with good lateral wall motion, a posterior pharyngeal flap can be performed. This procedure rotates a central strip of muscle and mucosa from the back wall of the pharynx up to the soft palate, creating a permanent bridge where the VPI defect is present. To determine which surgical approach is best in order to correct a VPI defect, an endoscopic procedure known as nasopharyngoscopy must be performed. Once endoscopy characterizes the size and location of the VPI defect along with identifying the velopharyngeal closure pattern, the following flowchart may be used to provide a general idea of which surgical approach may. Velopharyngeal insufficiency.
Okay. And now shortly about minor anomalies of mouth. Anomaly called labial pit or fistula. Definition: what does it mean? The depression located on the vermilion of the lower lip, usually paramedian. Evaluation, diagnosis, objective. Lower lip pits are typically seen in the Van der Waals syndrome. We mentioned about this syndrome earlier, which also includes cleft lip and or cleft palate. Lip pits may be connected to minor salivary glands in the lower lip. Occasionally, a lip pit may have a surrounding tissue elevation. Lip pits should be differentiated from pits located at the labial commissure cilium, known as commissural pits, which have no clinical relevance for us. Another rare anomaly: absence of uvula. What does it mean? It means that uvula is absent. How can we make this diagnosis? Of course, objective. And this anomaly is so rare. Or, opposite situation, bifid uvula. What does it mean? It means that uvula is separated into two parts, most easily seen at the tip, like here or like here. Evaluation, of course, objective. Although this relationship has not been fully confirmed, some have regarded bifid uvula as a marker for submucous cleft palate and have coded it under the heading Q35, which identifies cleft palate. As for me, this patient has hidden soft palate cleft. And synonym of this situation is double uvula. Thank you, doctors, for your kind attention.